a lot over the years, but it started called something else when I was a CA1. And it can be helpful. They kind of go through different topics in really short, easily digestible pieces of information. Maybe it's videos now. There used to be some quizzes that you could do, but I mean, this is several years ago. But sometimes the answers would be incorrect. So I'm assuming it's better now. Thanks. Take it with a grain of salt. True learning. I have the question.
Yeah.
Did you guys do like US Only World for the exams? So I think US Only World, the actual step is true learn to the board. It's a pretty good representation of the actual range of options.
What's that? Did you almost lose it?
Oh, no, I lost it briefly,
Or both basic and then your advanced. So it's really
Something like that.
used to be 300 something per year.
Yeah.
It's pretty crazy.
So we have to sign up for our basics at all different times of the year, or we all take it at once?
I think we all took it at once. Right?
Yeah,
we get, there's in 16, 17 blocked off for it.
There's a day.
We're assigned it, a date.
Yeah,
You can't take vacation.
2 dates. Everyone takes that one.
Yeah, it's
2
just
days?
It's 2 days.
It's exam 2 days?
No, they're 2 dates.
Oh,
And
okay.
you're assigned to either one or the other.
So remember, I
Doesn't
think
pick.
someone was trying to get a weekend off when we were doing it.
It was like,
no. And it was like, it's either Saturday or Sunday.
It's
no, it's Friday or Saturday.
Friday or Saturday. No.
usually graduation weekend.
Is that one of those prometric?
All the residents are gone.
I don't know. It doesn't take us
Don't fail or get stuck in the CA1.
Really?
Really?
If you fail, you get it.
Is that how it
You
works?
have to pass.
If you fail, you get stuck in the CA1?
No. I think you get to take it at least twice.
Just don't fail.
Oh, great.
I was the very first class to take it, so we all passed because I think that they didn't have a remediation plan to fail. Like nationally, if they failed a bunch of CA1s, they were going to be in trouble. So
Pass.
we just all passed.
You might have been like the baseline group
Yeah.
of like, alright,
I need that.
was this
Low
event too
bar.
hard to
Yeah.
be? Like, what's going on? How do we set it?
They only got 40%.
Yeah, exactly.
That
I need to sign up for my
What?
Oh, Dr. Bears,
What is that?
did you get caught in your hair?
No.
It's mine.
No? Okay.
It's down. I mean, normally it's in a fun. We're looking from VA.
Yeah.
You have to drive here after the VA for lecture?
Or walk there with you over there too. Yeah.
That's why they're more faces. Okay.
Yeah.
I was wondering where you guys are coming from. Because it's on campus now. So.
Yeah. It's not about walks.
Alright, well we can start talking. Andrew is
He's
okay. I forgot the gel, so Andrew is taking the day. This is to go off of a little bit of the regional that we talked about this morning, and then some things we didn't touch on just because regional is such a broad topic that you can't possibly discuss everything in half an hour, but maybe you've seen some things in the OR or heard about things intramural, and if not, we can talk about them now for the first time. So does anyone want to read the STEM out loud? This can be your participation. It's low pressure.
58-year-old male with ORF mid-shaft humerus fracture occurred after a fall. He had a BMI of 42 and also history of moderate COPD, which uses oxygen of 2 liters every day. He also has OSA, CPAP machine, which he tolerates, has diabetes type 2 controlling metformin with an A1C of almost 8, has CKD stage 2, chronic, how did he get that diagnosis? Chronic lower back pain, for which he's prescribed oxycodone 5 to 10 every Q4. He is humanly stable.
Okay. So first impressions off the bat of this patient. So he's coming in broken bone, big bone. They're gonna do an open reduction, internal fixation. So they're gonna come open, plate the bone back together. First impressions of this guy, super healthy. This is gonna be a piece of cake.
Not very healthy.
not very healthy. What are other kind of red flags that are kind of popping up, things that you're probably gonna have to deal with?
Bad airway. Bad airway.
Okay, so potentially bad airway.
Pain issues.
Yeah, so he's a chronic painer, so baseline pain when he's on opioids, so that's gonna make anything we do more challenging. Yeah.
He's on O2.
Yeah, so he's on baseline, who said that? Where's that voice coming from? Yeah, so baseline oxygen. So we're thinking, well, great, how's that going to be post general anesthesia? Other things that might be less exciting or more exciting, depending on your outlook.
It's pretty large.
Yeah. So high BMI, and he's on chronic pain medicine, and he's on oxygen. It's kind of painting a not great picture. Okay. So the topic of today, what is something that we could do to potentially help him out? Yeah, yeah. So what kind of regional block might you want to do for this guy? Okay, so we're thinking upper extremity, and then specifically some part of the brachial plexus. Yeah. Okay. And if his midshaft humerus, so brake is somewhere in here, things like, for example, an axillary brachial plexus block. Really great option for this guy in terms of just covering where the surgery is. First choice? Probably not, right? Because once again, that we're thinking, elbow, maybe a little bit above the elbow, distal. Okay, how about an inner scaling for midshaft humerus?
It would work. But he has COPD.
Yeah. So it would probably cover the surgery, but now we're worried about why do we care that he has COPD, that he has OSA, he's on oxygen? Why do we care?
100% chance of phrenic nerve block with
Yeah, so remember, where is that phrenic nerve in relation to the scaling muscle?
Over the anterior.
It's on the anterior border of that anterior scaling. So once again, interscaling, you're going to get spread. So 100% of the time, you're going to get the phrenic nerve with an interscaling block. Is what we're taught, right? Okay, so I heard superclav, I think. Okay, so that could be an option. What about infraclav? Sure, yeah, mid-hemorrhage. If we get the interscaling 100% of the time with this, the phrenic 100% of the time with an interscaling, what percentage of the time do we get it with a superclav? Yeah, so like 40-50%. How about an infraclav?
20%?
Yeah, 20.
I'm just guessing.
You just pick a number in medicine. It's usually
15 or 85.
20, 50, or 80. Those are your options, and you're usually right. Okay. So yeah, 20. And then once again, what percent? 0 for axillary. Okay.
That's a question about that.
Yeah.
I actually did 2 interscalings today
Yeah.
on 2 people with COPD. So like how much of a, I know that's a consideration, but how much of a contraindication is that?
So not necessarily a contraindication. It's one of those relative. So you kind of get the gestalt of, are they completely oxygen dependent, where they take it off, they do that down to 70. How?
Took me forever to find.
Thank you. Sorry. Just slowing you down. So we do these blocks all the time in patients with pulmonary disease. That being said, you can put a patient into respiratory distress in pre-op after you do this block. One of my friends from residency just called me the other day and said that she did an interscaling she's down in Texas, so the average size Texas patient, and had to call respiratory for BiPAP in pre-op because just taking out that phrenic nerve was enough for the patient to decompensate. So if it's a thin patient, they're only on maybe a liter or 2, well, they're probably still going to do it. And then it matters too, where are they going after surgery? Are they staying the night? I'll be a lot more inclined to do a block because they're going to be in-house on pulse ox than if I'm trying to send them home. Does that make sense? So, just to catch you up to speed, we have a very large, unhealthy guy on oxygen and CPAP who broke his humerus and needs it surgically repaired. And he's a chronic painer. This is actually most of our patients here. pretty representative. All right, and the BA. That's like spot on. All right.
PH too.
All right. So
That's so solid.
if we cheat and look at some of our questions, we talked a little bit about periodic analgesia, so if we'd like to do a block for him, is there anything else you need to know before we do a block?
If he's on any blood thinners?
Yeah. Yeah, why do you care? Because it's a peripheral block, right? Why do you care?
Depending on where you do it, if it was compressed.
Yeah. So if you were doing a superclav and you're kind of digging behind the clavicle and you hit the subclavian artery or vein, is that easily compressible? Not really. No. What about an infraclav if you hit the axillary? Not really. No. Interscaling? Yeah. Think about people who accidentally hit the artery when they're doing an IJ and hold a little pressure. Try again. So yes, axillary compressible. Yeah. So if he had if he was on warfarin and came in with an INR of 3, would that change? Well, one, the surgeon would probably consider it, but assuming that they wanted to proceed, would that change where you wanted to do your block? Yeah. Okay. So coagulation status. Talked a little bit about the patient's history and block considerations in terms of indications or contraindications. Would you say he's absolutely contraindicated? Probably not. Yeah. So what would you do? So taking all this information, saying he has normal coags, what do you want to do with block? You don't have to agree. There's not one right answer.
I mean, you say with the supraclavicular, yeah, that's the one that gets at everything, right?
Spinal bond, yeah.
If you wanted to be more targeted, I guess if it's mid-shaft humerus, I mean, axillary, you would maybe miss part of that upper part of that. That might be kind of risky.
Mm-hmm. So you're going super class?
Yeah.
Okay. Good choice. Yeah. Other votes? Really?
Infraclavicular,
Yeah.
just to reduce 30% or 20%. So,
Oh, yeah.
50.
That's the one that gets for Nick. Oh, yeah.
50% of the time.
Okay, yeah, let's reduce this.
So good. So infraval would be a good option. You can make an argument. Now he's BMI 42, so might be challenging, but worth looking at least. You guys, I wear a high necked shirt. Does anyone want to be a volunteer so we can look at the brachial plexus on them? If you don't mind getting gel on your neck. All right. Does anyone want to be a scanner? Yeah. All right. Thank you. You're a lovely patient. And then you come over here. Let's see. Yeah, 30 degrees. Just for time. Yeah. I'm gonna adjust your hand. Sorry. We're gonna do heels. Do you want to take your just want to do it? Okay.
Complain and
I know.
So, first thing you want to do is identify which side of your probe is which side of the screen. And you can cheat and not see that little symbol here, that little groove. It's different. That groove corresponds to the GE symbol on the screen. Okay. So otherwise, I still tap it. So I know that, but I still tap it. And then what you're going to do is, actually, I lied. You should stand right. Can you see this? Maybe you stand. Let's do the other side of the neck. And then you can look this way and you can see the screen too. Okay. So the way a lot
I
of
wish we could have that slide from this morning.
I know. Oh yeah, I can pull it up.
Oh, you heard it?
Here, let's pull
I
it
don't
up. Good
know. I
Tell me which one.
All right, so starting,
And we're doing an infra class?
well, you're gonna scan the brachial plexus. So
Okay.
I think it's a really good strategy to do it the same way every time, because you get to know normal anatomy, and then when people have abnormal anatomy, you can identify things.
Okay.
So what you're gonna do is, do you mind if I touch your shoulder? Okay. So you're gonna feel her clavicle here,
Okay.
and then you're gonna put your probe
Could
right
you
behind
mind
the
if I
clavicle.
touch your shoulders?
Alright, so just gonna right parallel to the clavicle. Yep, perfect. And you're gonna hold your probe like this.
Okay.
Savage.
So now you're gonna tilt.
Hold probe.
And what you're looking for is her, I think, yep, right there. So, which artery are we looking at? You can cheat. Subclavian, yeah.
Once it crushes the dead
Everybody
plant.
Everybody just read.
Once it crushes the dead plant, that's what it's at.
I took way too much. Okay, so now what you're gonna do is you're gonna just gently twist and try and really sharpen it up so your artery is a nice circle. Just small movements there. Okay, so you see how your artery is a pretty nice circle? This is lateral here. You
Okay.
see these little black circles that look like chocolate chips?
Mm-hmm.
Those are all your divisions at this point.
Okay.
So that's all brachial plexus, which is nice brachial plexus, just spread out like that, right?
Mm-hmm.
So now you're very slowly gonna bring your probe, you tell us the permission to it, up your neck, tracking those black circles. So track those, keep them in the center of your screen. You see them and start to condense.
Cool.
Go a little higher.
Whoa.
Beautiful.
Hey,
Check
stop
that out. Okay.
Slow clap.
So this is lateral. This is medial or anterior. So which scalene is this? Yeah, anterior scalene. Which scalene is this? Middle scalene.
Okay.
So you are interscaling.
Okay.
Interscaling,
Oh,
right?
dang.
So
So that's
here,
it, that's where we go for interstate?
yep, your target would be that kind of white connective tissue line, right?
Where are the dangerous vessels?
Yeah, I see that.
Medial.
Okay,
There we
that's
go.
what you're doing.
That's miles
Touch
away.
that.
Okay,
So
wow, okay.
would you like try to
It's like a
just
centimeter.
would you just try to like get to the very superficial part of that and then just inject or
So we come in from the posterior side.
okay.
We come in.
I just found
White, when you're really proximal, white is connective tissue, right?
Excuse me,
So
man, can you hold your-
these are roots, which means that big black, that's 100% nerve. So you don't want to touch it.
Okay.
The white in between is connective tissue. So typically the target is between the head and the body of the snowman, that white connective tissue, because that's going to be between C5 and C6. And
Where's
then
the chocolate
less
chips?
you're getting. Yeah, right here.
So then you just make the
You follow the
subclavian
line.
artery more sharp,
If you were going to do a super clap,
just so that you know you're not going to go inside of it.
exactly. And then you could just slide it to the side of the screen because you're going to come in this way.
On the side this way. So like that.
So you just slide it, you kind of rotate it, go back this way. There you go.
Oh, I see. And so now we have
now you have real estate to come in with your needle, and your target is that, they call it the pocket, the corner pocket. So like a pool reference.
Yeah.
And that's where, so that you don't miss the owner, or if you go to the corner pocket. So if you map where the divisions go, those are the divisions that eventually contribute to the ulnar nerve when they crisscross again. So once again, so an interscaling block is going to be really at these trunks, or the roots, sorry. And then when you do a super clap, you're kind of blocking more down here. So that's why there's so many little black circles, because you have so many little divisions at that point. If you were to do a infraclav, you're down at the cord. So really you're back to 3 things. And then axillary, you're getting all the small things. Do you mind if we look at your infraclav, just where they were your collar button? anatomy. So you pick, so you're gonna do head on the left, feet on the right,
Okay.
based on how you're holding that rope. That's fine.
Head on the. So head would be this way.
So head's gonna be on the left side of the screen.
Oh, right. Yes. Okay.
Right.
Right. So what you're gonna do is right below her collarbone, up and down. You're gonna work with the probe just like right there. Yep. Once again, hold it like a pencil. Okay. And you're just gonna look right under the clavicle. Okay, so we're gonna identify her axillary artery, right? Because it's pressed under the clavicle, so it's not just a claving anymore. So we gotta look up a little bit. It's really, really, so here's clavicle, bones, can't see anything. Here's your subclavian artery. If you let up a little pressure, you'll see her, you should see her vein open up right next to it. We can trace it out. There we go. Better picture there. There's the vein. Next to it, right there. You see, let up a little pressure. So your median cord is going to be in the middle between your artery and your vein. Posterior is posterior, and lateral is opposite medial. So if you remember your median is in the middle, you can figure out the rest.
That seems like a tricky one.
They like for some reason, axillary, infra, we won't do your axillary because that's major. But axillary, infra, and ankle blocks always comes up on ITEs. I don't know why they love those blocks so much, but they do.
Which one's axillary?
Axillary, infra, and ankle blocks.
Oh yeah.
Oh yeah, that's what direction.
I was like, I don't know why, they're always on the exam.
So that was in for cloud.
That was in for class. So you can see why, if you're putting your local all the way down here, we're going to get the phrenic nerve that is all the way up here, less likely, but still 20% of the time. So, something to think about. Now, we have a thin model, right? This guy, BMI of 42, so he's not necessarily going to have such beautiful superficial anatomy that can make these spots more challenging. Makes sense? Does anyone else want to try scanning, or I'm volunteering you, sorry, or be scanned?
I want to try
Okay, I'll be seen.
something.
Oh, thank
Probably I
you.
got something.
Yeah, thank you.
I would volunteer back my.
Volunteer paper dispenser.
Can't get the photo.
Yeah.
Wow.
It's nice that you're seeing different people's anatomy because everyone is slightly different. I have kind of a crummy inner skin, but my super jaw was okay. I checked because I break my arm and I need a block.
Yeah,
Hold it like a pencil.
Yeah.
And then you're gonna do either way. So that little line here, that groove, that is the GE marker. So you can make
Oh, the U as opposed to
exactly. So
Everything.
you can make left, right. You just have to so start right behind the clavicle, up and down, right behind. It's just like that. And rotate your hand down. And then what you're gonna do is scan until you find the artery. So it'll just be a matter of
I guess real shallow, but also like
you won't see the clavicle.
teachers.
Yeah.
Like really learning things.
The shadow from it.
Dude, I got the thumbprint today.
Oh, you did?
20 minutes.
No way.
I literally walked.
Are you all set up?
No, I gotta go back and get the badge.
Oh, okay.
I just did the first step.
Well, it's good that you're doing it like way in advance.
Well, 3 weeks. Hopefully that's enough time. Okay, yeah.
Either way you go, you need to show me.
That's what I heard. I talked to one of the CA2s today, and they're like, even if they say something already left there, you show up.
They'll make it in. They'll try and work. But even if they can't figure it out, like, the attendings will say. Like, just tell the attending it'll be like all set up.
Yeah.
Good resolution.
No, I mean, it's like the
Those components are so huge.
Little rotated
I think that's impossible. Huh?
That's gonna be really hard.
What?
No, I
Hold and like put the needle in.
I was thinking you could use your left hand, right? Because I'm like,
I understand.
Was that? I was holding with my left, right? I was holding with my
on
left.
the first one, I think you were doing it right, right?
Oh, no, you're right. I was holding with my
Did
right.
the input really do it?
Seems
So where
yeah,
was
that's
I?
hard.
Yeah.
That looks like good one.
Yeah. How are you supposed to get between the other and the other?
It's like sandwiched right there. A lot of times when I'm doing these, I do sideward angles and like all and then for like good.
Trying to rock.
And then I'm like trying to find it. And
I've been thinking I'm gonna go be figure skating and I'm gonna go about half this. That's the easiest. Just take a deep breath.
Yeah.
Breathe harder.
Yeah, that's
I
what
can believe this. You can rotate a little as well. Still in the center there.
Yeah, that's so.
Five different
nerves. So obviously can't leave a catheter there, right?
Huh?
Can you leave a catheter in that?
I don't know if they do.
Oh, this one.
I would make sense.
Okay.
Partially is we have a permeable ultrasound because there's a Wi-Fi, so I can So a little bit less clear of a picture of the scaling muscles, but you can still trace those bundles up and down. So part is a little positioning, part is a little ultrasound teaching. I imagine you have a very nice but you can trace it back down and back up. So even if you have someone that's like a bigger neck or a weird anatomy, if you do it the same way every time, so you identify where it is at this
Our friend
who's
who's
super
the
copy, you
guy.
can trace it up, you can trace it down. Had a couple of patients who've come in and they had major neck dissection surgeries and they're coming in for a shoulder. So their neck muscles aren't normal.
Maybe rifle.
But we're still able to identify kind of where the scalings were, where the nerves should be, and then to a safe and successful block that way.
I might use rifle one day and then come back.
The first one was super flat. The second one was amazing.
We can do like, yeah, we'll do rifle for day trip and come back. Sunday morning.
It's so beautiful.
No,
It was pretty.
I don't know what to do. Oh, I'm gonna be.
in the OR, or I should have brought that in the
No, I was asking where you're gonna go.
Here, I'm doing
Oh.
this here. This is
I don't know actually. I think we're actually I think it's gonna run our house.
And I was
How
like,
does
fine,
that
this is
happen?
10 miles.
David,
Oh, did you talk
I won't
about
go do that. But
I like to say that.
oh why? She's like 42.
The minute you open it is when, like, literally the minute I open the syringe thing,
She like helped, she didn't help break me, but like
What does she
and I
been
was
down
like,
for a long time. At a good age.
what, you want me to?
You want a goop?
Plus, we don't
I mean, if someone else wants to scan, we can scan. But as we're kind of doing that,
You guys want to go in? I think we're going to
is there?
Alright, somebody hand me needles.
I just
I'm ready.
Alright, let
So
you
this
know.
guy
Chill or relax.
Yeah.
mid shaft humerus fracture. Are we concerned neurologically, neurovascularly about anything related to this
Pretty sure I'm
injury?
missing a brace radial.
Yes.
Which one?
I said radial.
Yeah, how do you remember that?
What?
I memorized it during anatomy first year.
How do you still remember?
Spiral groove,
So-
yeah.
So mid-shaft humeral fracture, are we concerned preoperatively, not related to our nerve block, about any neurovascular injury related to the brain? Radial nerve, right. I remember ARM, A-R-M, depending on where the break is. So mid-shaft is going to be your radial, ulnar, like at your, what's the fancy word for elbow?
Epicondyle.
Yeah, it's going to be your median nerve. And then like a really proximal, you could potentially get your axillary nerve as it's going, so ARM. Yeah, so radial nerve. So this is this patient's a chronic painter, you could definitely use a block. Do we want to do the block pre-op? No, I see some shaking no, why?
Because they'll want a good neuro exam.
Yeah, So a lot of times these surgeons, after especially kind of elbows, mid-humeral, they'll want to check the radial nerve post-op to see if it was injured, either if it's intact before surgery, is it intact after the ORIF? So a lot of times we'll consult these patients for a post-op block. How do you check ulnar, median, radial nerve function in PACU very quickly? Yeah. So which is this?
Median. Median. No.
Radial.
Radial. Okay. This is median. Median is like your ability to.
Dr. Young, you want to help me on this? That's ulnar?
Ulnar.
What is it?
Because
it's
Oh,
intrinsic.
that's
intrinsic.
that's why I was
Radial.
Radial.
So in PACU you can be like, well, your patient can do this.
And then you'll see the.
What is it, Star Wars?
He's going.
Star Trek?
Hey, how you doing, man? Doing good? Yep. All right, you're good.
Yeah.
Thanks.
So okay, so great. So like maybe doing this PACU, what if he couldn't do this? Do you block him? No. Don't block him. So yeah, so call the surgeon. Be like, hey, concern for radial injury. Say the patient, the surgeon comes out and says, oh yeah, we saw the radial nerve. It was really stretched on the field. I expect it's going to take days if it gets better. You can go ahead and block him. You block him.
Did blocking damage the nerve?
Could. So they call it the two-hit hypothesis, so that if there's pre-existing nerve injury and then you then block, you could potentially compound. Is underlying nerve injury an absolute contraindication to block?
No.
No. So it's a gray zone. So in this chronic painer, if the only way you can get into a tolerable spot is with block, you might block them and document the crap out of it that this was pre-existing. You could try not to block them and try other things, but in some of our bad chronic painers, you might end up still offering a block despite knowing there's some underlying injury. It's going to be a conversation you'll have with the APS attending that day or fellow, the surgeon, the patient.
You just talk to the patient, ostensibly just let them know, hey,
Yeah.
this will probably help your pain, but also it's an increased risk for you because of this.
I can't tell you I won't cause harm. It's low likelihood, but not zero risk.
The question is if you're an anesthesiologist for a super athlete,
Yeah.
do you give them their blocks? Is there a trend to preserve function? I don't know.
So we've done it both ways. There have been some ultra athletes that just we mention that it's a thing that exists, so that we're not holding back care from them, but we don't kind of push it. But then there are some athletes who want it, so they get them. The chance of nerve injury is still very low, but if your entire career and livelihood is based on your ability to throw the ball, maybe it's not worth the risk.
What is the risk? One in.
Don't ask me the numbers. One in 30,000 for some sort of. It's not zero, but it is unlikely. When you do see, I've been fortunate that I haven't had this, but I have seen patients that it has happened to, and typically it's a very persistent sensory block. A lot of times they'll get complete motor function back, but it will have a distribution of numbness. Typically that also gets better with time, but it can take months. It could take 6 months before that completely resolves if it does. We do have protocols where we send them for EMG testing to try and determine at what point did the injury occur. Sometimes it's not us at all. We're just a really easy target because anesthesia is very mysterious. So it's easy to tell your patient, it's probably a block. When in fact maybe it was positioning during surgery, they were in a retractor, they had a tourniquet that was up for blockers causing some ischemia there. But usually it's not usually a very easy fix 100% of the time. This is it.
I had a patient in pre-op clinic the other day that told me she had a block from her shoulder and that she had like lymphedema from it. Is that a thing that can happen?
Potentially, was it the left side?
Yeah.
Okay. So, what do you know about lymphatic drainage? Yeah, so potentially you could get a duct injury. It's more common on the left than on the right. Same idea why we do more of our central lines on the right than on the left. It's still rare, but it's a possibility that there could be some injury. How much clinical swelling that would cause, I don't know. All right. So let's say he did give you the thumbs up. You went ahead, you did a superclass block, and then he tells you, he's like, oh my gosh, my pain's so much better, thank you. 5 minutes later, he tells you he fears he's going to die. Last, okay, so local anesthetic toxicity, what else could this be? You're poking him right here. Yeah, so maybe you got the apex of the lung. Yeah. What else? Yeah, so he feels anxious because he's losing that diaphragm benefit. Okay, anything else?
There's a fracture, we also just have PE.
That's a great thought. So this could be completely unrelated to anything we've done, and it could be a PE. What if, what would you do? How would you figure out what you need to do? Do you need to get intro with it? You know, if it's PE, you don't need intro with it. So how do you decide?
We get an ultrasound there, you can just look at his flow lining.
Yeah, so you do a little POCUS and see if he has
Seashore versus
the pneumo.
barcode.
Mm-hmm. So you can check for pneumo. You could put the probe down right below or right above the spleen and look for diaphragmatic movement. So you can kind of really quickly either rule in or rule out those. You can get EKG, yeah.
Now, if your stomach still like you're obviously still breathing with your stomach, and it's going to push can you sometimes be fooled into thinking the diaphragm is working when it's really not? Or will it just kind of be?
That's a good question. Typically, on the plane that you're looking at, you're kind of looking more internal, not just the external movement, but kind of relative shrinking.
Okay.
But I don't know. If someone was really belly breathing, you mean?
Mm-hmm.
Tidal rocking.
Yeah. Okay.
Yeah.
What kind of?
It would make the exam really hard to begin with. I don't know if that could confound the picture. All right. He's fine. He was just a little anxious. He's waking up. He's fine. So, if we did a superclav kind of distribution, what are we expecting? In terms of block. Sorry. Yeah, the whole arm. So you're gonna put him in a sling. You're gonna tell the practitioner to put him in a sling. Make sure it's padded. Say we did an axillary one more time. What are we expecting? Okay, so can they go like this?
Yep.
Yeah. I mean, he might not if it hurts, but yes. And then interscalene is traditionally in ulnar sparing. So if it's ulnar sparing, what might the patient do? Yes. You see it all the time in the shoulders. They're like, I can move my fingers. Congratulations. Okay. I know it's Friday. Let's do a little bit of the second case and then finish because I'm tired. Okay. Second case. We will not ultrasound because it is a little bit more invasive. All right, reader.
Your 88-year-old patient has just received an adductor canal block for elective total knee replacement. Her block contained 20 mLs of 0.5% ropivacaine, 75 mics of epinephrine, and 50 mics of clonidine. She's 55 kilos and her BMI is 21. She has a past history of hypertension, which is controlled on 5 milligrams of amlodipine. She also takes atorvastatin for hypocholesterolemia, but denies any other medical history. She is a lifelong non-smoker and has never used alcohol or marijuana. She's insulted that you asked. She lives with her husband, for whom she's the caretaker, and as he has developed dementia. She generally feels well, still drives, and does water aerobics twice weekly at the YMCA.
All right, so first off the bat impressions.
She's killing it at 88.
Yeah, right?
dang.
This is
Dang,
pretty
girl.
impressive.
Yeah.
88 water aerobics.
Near.
Mirrors like that, 5 of them lodopine. Like this is
She's doing
this is
great.
I'd
little
love to be
things.
like her.
Yeah. So she's the opposite of our first patient. She's doing great. So what do you think about the cocktail of medications that she got for her adductor canal block? So adductor canal is where on your leg? Yeah, mid-thigh. And what are you blocking? Sensory to the knee. So saphenous, your nerve vastus medialis, all those terminal little sensory branches.
Anterior part of the knee or the.
It's primarily anterior medial, less lateral. Okay, so does that seem like an appropriate block for someone that's having knee surgery?
Yeah, not a total knee replacement. Oh, okay. Yeah.
Yeah. I mean, could it be your only anesthetic for a knee replacement? No. But for post-op analgesia, is it a good option? Yeah. Cool. Okay, so she's at least getting an appropriate block. She already got it. So that's good. Did what they give her, is that reasonable?
No idea.
Okay.
Sounds good.
Yeah. So have you guys talked about local anesthetics? Yes. What do you know about ropivacaine compared to the lidocaine?
It's longer acting.
Longer acting.
It's much more toxic though. It typically hits sensory before motor more.
Compared to
Lidocaine.
or
Or bupivacaine.
Yeah.
And then it's
So-
less toxic than bupivacaine, but about 40% weaker.
so if you are doing a post-op analgesic block, typically you want that to act a long time or a short time? A long time, right? Otherwise, why bother? So if you're going to do an analgesic block using a long-acting local anesthetic, good choice. So ropivacaine is a long-acting local anesthetic, good choice. You're right in that if you're going to compare ropivacaine to bupivacaine, it's a little less potent, milligram per milligram, and we call it a little less cardiotoxic. Bupivacaine is kind of our big buzzword for cardiotoxic local anesthetic. Okay, so ropivacaine, 0.5%, great choice. Did we give her too much?
That's a lot.
I don't know.
I don't think
What is normal?
So what is normal? What is the maximum amount? What's the easy way to remember this? Yeah.
So like in that range.
Yeah.
But this is 0.5%, so it's
This is
double.
still only 100 though.
So how do you remember that? How do you remember 2 to 3?
For ropivacaine.
Or bupivacaine?
I don't know. You just remember. I just remember.
2 to 3 what? cc's
Milligrams per kilo.
per kilo.
Okay, you want the cheat?
Yes.
Yeah.
So, well, half of you get the cheat. The other half can't see this. Can I put this up?
Totally.
Still works.
Well, you can read it down here. So for ropivacaine or bupivacaine, you can typically do 2 to 3 milligrams per kilo. Let's call that 2.5 milligrams per kilo. Okay, we agree? What percentage ropivacaine, bupivacaine do you always hear surgeons ask for? 0.25% marking, right? That's what everyone injects. So 0.25% equals, move the decimal over, 2.5 milligrams per ml. If you get 2.5 milligrams per kilo, 2.5 milligrams per ml, the milligrams cancel out, you end up with 1 ml per kilo of 0.25%. So if you get 1 ml of 0.25%,
It's like they
how
planned
many
it that
mLs?
way.
I know, right? How many mLs of 0.5% do you get? Half,
5.
right? So it makes it pretty easy. So yeah, so she's 55 kilos. Did we give her a toxic amount of ropivacaine?
No.
Probably not, no.
Starting to get close though.
True. I mean, I guess it depends where you put it, right? If you put it all in the blood vessel, yes. Okay, cool. So assuming it's in the right spot, that's a safe amount, great. What about epi and clonidine? Why might you add those blocks? Yeah. So epi, maybe a little vasoconstriction, less uptake if you're looking aesthetic, a little bit longer block duration. Clonidine, kind of the same idea. Prolongs block. Yeah, we don't really know exactly.
But if you're using them like an epidural or if you're using spinal, then it's totally different.
Yes, yeah.
mechanism
Typically for
prolonging.
spinal and epidurals, there are some studies out there where people have done these things, but typically we don't hear.
Man, what else are we putting into these things?
What'd you say?
What else are people putting into these blocks?
Do you mix them?
Yeah.
It's like randomly pick
People do strange things.
It's like carbamazepine.
Do you mix adjuncts in your blocks? Is that like kind of common that you would mix, or would you usually just stick with one and go with it?
I don't know.
I wouldn't put Tylenol in my blood, but when we don't have nationwide shortages of clonidine, yes. Right now, I think we have 3 vials for the whole hospital,
Gotcha.
so no one is getting clonidine in their blocks. We do add epi to our adductor blocks, mostly for not only block prolonging, but if you are intravascular, what might you see? Cardiac, right? Hypertension. So it can be a marker of intravascular injection. Okay. So really quickly, if we breeze through some of these questions. All right. We talked about the drugs. What do you know about mepivacaine? Nothing. Yeah, the mepivacaine is pretty much just like lidocaine. For a block, you're going to get 3 to 4 hours, so really short. And then it's a higher milligram dose before you reach toxicity. But really, the only time we're going to use mepivacaine on a lot of the blocks here are going to be for AV fistulas, because it gives a really dense surgical block that then wears off pretty much before the patient's leaving the hospital, so less chance of the patient having a numb arm and injuring their new fistula when they're at home. But otherwise, is mepivacaine a good option for post-op analgesia? No, right? I will say I was on APS one time last year, and I didn't ask the resident which medication we were using. So we did a mepivacaine block for a total shoulder, and then did a bupivacaine block for a total shoulder and it was fine. The patient was very comfortable. But, yeah. All right. We talked about toxic dose. How long should it last? They're
3 hours.
For ropivacaine.
Ropivacaine.
12.
Yeah, like 12, maybe 16. It's pretty typical. It depends on where you're doing the block, but I'd say that's pretty typical. Why do we do adductor canal blocks for these compared to a femoral?
Is it fall risk and then also clot risk?
Yeah, so why fall risk? What do
Because
you mean by
you
that?
take out their motor nerve as well, and then they don't.
Okay.
They'll think everybody's fine, but they stop.
So a couple of years before I was a resident, we did femoral nerve catheters and sciatic catheters for these new patients, where essentially their entire leg was anesthetized for 3 days. We've come so far. Now we're like the other end of the spectrum, where we're barely doing just a sensory block for these patients, for those reasons, so that they can get up and do physical therapy and move better. So yes, so fall risk. Say you did a femoral block for this patient, what would you have to do post-op? If they're like, we want them to stand up and wait there, what would you have to prescribe this patient?
Immobilizer.
Yeah, it's like read my mind. So yes, immobilizer. Yeah, you have to kind of essentially give them a locked knee joint because their quads are going to be completely anesthetized, and if they go to bear weight, they give out.
Has opiate use post-op gone up since moving away from the more aggressive?
Not significantly. No, I mean
Cool.
it used to be like 0
Yeah.
because they were numb for 3 days, but they were also in the hospital for a week, and now the patients go home post-op day 1 or 2, so they're doing pretty well.
Is it nationwide we switched or mostly here? Like when you said
So we as an anesthesia field,
like nationwide.
more academic centers than some of the other more practice centers. But yes, nationwide the trend is moving towards adductor canal sensory development block. That's a great question. We was vague. All right. What if after 5 minutes she tells you her mouth tastes like metal? She's like this funny taste in my mouth. It tastes like metal. Concerned?
Yeah.
Why? Yeah, the theme, right? It's regional. Last. Okay. How concerned are you? Are you telling your co-resident to go get the intralipid from the Pyxis, or are you like, oh, let's see how this goes?
You don't have a catheter in there, right? You just inject
Just
it.
a one-time injection.
Just watch her. Just watch her.
Get
You don't have
set
a
of
toxic
vitals.
dose either.
Right. So it's this.
No set of
I mean,
vitals.
let's be real. I'd probably
Yeah.
take the intralipid.
Yes, please.
I have it there.
Yes,
Let's
check
rehearse.
vitals. That's a great idea. If she's not on oxygen, maybe you put her on some oxygen.
Right now, I feel
Give her some fluids. Yeah.
Also, how do people know what metal tastes like?
Are you kidding me?
Bit down on the
Come
floor.
on, tell me you never like battery when you're
Have you never tasted blood?
Tell me. Salt.
You never like
Good.
a 9-volt?
Metallic.
I don't
Sorry,
know.
maybe
It's
that's
like
not.
you bite into it, you get that,
Lick the battery? No?
Just kidding. Like everybody's like the 9-volt, man.
It's really makes sense. It's
You gotta
like your
know what it's
metallic.
like.
It's like an 8. You don't need to.
You'll know it.
like. What if
I'll buy you
you?
an 9-volt.
At the bar, okay?
What if she seems confused to you? Like
That would be
she is this like super lucid 88-year-old.
And you didn't give her any Versed pre.
She got no sedation from
Yeah,
her
she
block.
shouldn't have gotten.
And then she's like, oh, it tastes like metal, and then she starts acting a little.
Yeah, I'd have the intralipid.
Alright.
I would call my attending. I probably would have already called him about the.
What does the
the-
intralipid look like? Is
White.
it
White
glass
like
thing?
propofol.
It looks like-
Oh,
Oh.
It's
You
just
said
like propofol
TPN,
or
okay.
TPN lipid.
I think it's just the back.
Oh, I don't know.
For the neurologic ones, is this where you consider giving benzodiazepines?
Yeah, so like maybe you would give her benzos if you were concerned she was heading towards seizure. And what do benzos do? Why do we give them to try and prevent or treat
Raise the
seizures?
seizure threshold.
Raise, yeah, exactly. So we're just trying to stave off seizure. You could maybe get the intralipid, call for help. Say you get the intralipid, you gave her the intralipid bolus, and her vitals are super stable. She's now lucid again, talking with you. She's like, oh, I feel great. Do we do the case?
I don't know. Is her leg still numb?
Can we postpone the
She's
case?
on this right here. Yeah. In a strip of skin. Yep. Block's working.
Can we put the case off for a little bit and
How long is the
monitor it?
case? How long is it?
45 minutes. Dayton's doing it.
How long?
45.
On
Dayton's
total?
doing it.
Let's do it.
Let's go for it.
Let's do it.
Are you going to
We were
Oh my gosh, yeah, that hit. It would take 5.5, 6 hours.
Jason,
If-
call
If you're sedated, you might not be able to assess her though during the case if she's
Yeah.
sedated and she
Yeah.
can't
That's a
give
good
you
question.
feedback because
So
intralipid-
you're going to see people do this different ways. If the patient's otherwise stable, doing great, there are going to be people who do this because you're going to say, well, she already incurred the risk of the block. Let's do the spinal, do the case. You can talk to her through the spinal. You might not give sedation, but you can talk to her, you can assess her. There are people who say, like, nope, cancel, let's monitor her for pick a number of hours and reschedule. So I don't think there's one hard and fast rule, but you have to have a reason why you're doing it. And just document that.
Question for this lady: when you were saying give her a benzo to raise her seizure threshold,
Mhm.
like the whole reason why we went through this whole block rigmarole in the beginning was to try to avoid delirium
Yes,
causing agents.
yes.
Could, like, let's say we're in.
But then you give her last. So you got to treat it.
So if we're in like either the pre-op area or the ICU setting, is it reasonable to throw her on some Precedex? So then you decrease the delirium risk and you raise her seizure threshold?
Precedex is like just a lesser.
Or could you just let her seize if she's going to seize and give her a benzo if she seizes?
So there's been studies that
'Cause a little
Precedex
seizure's not gonna
does
hurt
treat
anybody.
withdrawal seizures.
I mean,
And the other thing was that it actually is supposed to help ICU.
as long as she's in a
Yeah,
safe
but
area,
in
seizure
contrast to the
precautions, you can have it ready.
Really?
Slam it
Yeah.
if she
Yeah.
starts seizing.
It's a big critical care.
There's
There's like a big critical care like article
Maybe you give her a small dose of benzo.
Yeah. I mean, in kids we watch them sleep for 5 minutes before we do.
True. This is an 88-year-old. She's doing great, and we want to get her back there, right? We want to get her back there.
Compared to your fentanyl and benzo. So that you don't have a good control. Right.
And just like anecdotally, in the eye center, these patients come and they get a milligram of potassium for cataract.
Yeah.
1 milligram of
And she's high functioning anyway, so
it's not gonna.
it's true.
Precedex. So Precedex, yes, it affects seizure threshold, but what does it affect in terms of cardiovascular status?
Bradycardia,
Hypotension, things that if we continue
And
in
sedation.
that last progression could become big issues for us. So I wouldn't use it in that situation just because you might compound hypotension or some arrhythmia that you would potentially have later. Would you intubate her? No, she's awake and talking to you, right? Like, she's fine. Don't, if you are concerned that she can't
hold
still.
Excuse me 1 moment.
Okay. So now she seizes. She's still stable otherwise. Can you're standing there and you have your bag of drugs and you have 2 vials of propofol. Propofol is 10% lipid. Can we just give her some propofol?
no.
Why?
Specifically says,
Yeah, so same deal. Hypotension, cardiac depression.
and it doesn't really work that
It's just
well,
more
right?
dangerous seizure, or
We talked about last the other day, and they were talking about how propofol is a very small percentage.
Yes.
Lipid. Like
Yes.
you need, like 1,000 milligrams.
so even if she's seizing, you're just
You can give a
benzos.
little benzo. Yeah,
Just keep okay.
give a little benzo. Give your 2 of the bags.
Question: in an actual situation, if you had propofol in your pocket and had to go to Pyxis for benzo, would you give the propofol?
Probably not.
Still not.
Well, so is this last seizure or is this
last
seizure?
seizure.
Last seizure?
Yeah.
What is
Probably-
last seizure? Is it like partial or is it?
Sorry.
general?
Like, is it seizure from local anesthetic toxicity or
Right,
is
like
it
is it
seizure
really
because the
bad?
patient
Is
has
it like are they like complete seizure or
one?
they're just like a partial?
The one I've seen was
Yeah.
like tonic-clonic
Okay.
shaking. There are case reports out there, kind of more of a almost like an absence type, hypoactive, just out of it, confused and unresponsive type seizure.
So it can be
But
pretty much bad.
yeah, I mean, it's the whole neuro spectrum of either agitation all the way down to coma. You can have the last. All right, so we briefly mentioned it earlier today. How is ACLS altered? So say she seized, now she is hypotensive, and she's 40/20 blood pressure on the cuff, and then you can't get another reading. So you can't feel a pulse. You start ACLS, you start chest compressions. What else? What do we do? You're calling for help. Yeah, it's tiny amounts of epinephrine. What is tiny?
So like
Under 100.
Yeah, so like 50 mics, 100 mics, somewhere in the half to 1 mic per kilo typically. So this lady is 50 kilos, so I'd probably start around 50 mics for her. Vaso is a good thing or a bad thing? Bad thing. She has an arrhythmia now. Do you want to give some lidocaine for the arrhythmia? No, don't do that. They write it specifically out because people have done this. Okay. And then what do we really need in order to coach? And then if the intralipid, we bolus the intralipid, and we start the infusion, we're still not getting return of circulation. We go to we put her on bypass, we put her on ECMO. This happened here probably when I was a CA2. It was I think otherwise healthy young female who was coming in for some sort of knee surgery, got in had a canal block, and then had cardiovascular collapse and pre-op. Ended up getting intralipid and then being put on ECMO. She did great. A couple days later. But I heard it from someone who heard it from someone who was there. So details.
So she survived and did okay.
Will she ever get a block again? Probably not. But
Is it the operator error or patient anatomy? Like, what's the stigma?
Yeah.
Like,
So basically, you just need enough of the local anesthetic in the bloodstream. Whether that is because it was a direct intravascular injection, is it that you went through a small collateral, injected in the correct spot, but then there was enough uptake in the open vessel to reach the toxic level? Is it some sort of patient-specific factor, like they have very low albumin, so there's less protein binding, therefore higher free levels, so they are relatively higher toxicity compared to someone with a normal liver. Like older patients are more likely, patients that are beta blocked, presumably because if there's an intravascular injection, you might not notice. So there are lots of things that can contribute to the likelihood of getting lost in a really young, otherwise healthy person with an ultrasound guided block is pretty rare. But it's common enough that you will see this more than likely at some point in your training. I had a case, my CA 2-year, for me, we were doing a lumbar plexus block, which is the worst block ever. It's a blind block based on anatomy, and you're using a needle that's, 10 some years, and it's for a hip revision, so his anatomy wasn't normal to start with because he had already had scar tissue, and it took us probably, 10 passes to get to the plexus. Never got any heme on aspiration, no vital sign changes on the monitor with injection. Same with Bob, he was 93, and I was like, okay, Bob, we're all done. He says, great, okay, Bob, I'm gonna help you roll back onto your back. Okay, tonic-clonic seizure. So I think what happened was with one of the passes, I nicked some vessel at some point, and we injected the local. He had enough uptake for a 93-year-old that he seized right away. No cardiovascular issues. We gave some intralipid. He was awake, conversant. We sent him to the unit, canceled his hip. And he got the hip done at a later time. So, like a pretty mild blast in the grand scheme of things, but like stuck with me.
That's scary.
Yeah, that was in pre-op. But yeah, it was like perfect timing. Caught one of my classmates walking by. He kind of just held the ambu bag. He was breathing the whole time, and another classmate had on cardiac, and he had a bucket of cardiac stuff. So I was like, well, I don't think we need anything right now. Just stay right there. And we had 20 people all helping, so it was very uneventful. But
What's the number you call again for anesthesia emergency? There's a number you call if you need help.
I would call the charge attending or yell at one of the pre-op nurses. Yeah, call for help. Yeah, they get overhead page too.
Where is intralipid stored at the U?
That is a fantastic question. So it's in a couple of places. It's in pre-op Pyxis, and it's under either fat emulsion, also intralipid, I think, or lipid. They keep it up on OB as well. They keep it in AOP. There's a block cart where it's just in the, you can see the top of the second drawer down. But yeah, it's in a couple of the Pyxis around the hospital.
But it's not in like every block cart like the VA.
No.
oh, there's one in every.
I mean, there's not a lot of block carts.
Okay.
Let's be real.
Can never find it.
Sometimes.
But it's something to be, if you're up on the floor doing rescue block on the 8th floor, your intralipid is on the 2nd floor in Pyxis. Right? So it's something to think about.
Like, do you take it with you in that case, or you just
After like
I need to
ultrasound,
remember
right?
that happens?
Because, I mean, the chance, I've seen it once, right? And I've been doing this now for 7 years. And I do a lot of blocks.
Right.
So it's rare, so we don't carry it everywhere with us. But you want to make sure it's good.
Okay.
How expensive is it?
Intralipid?
Yeah. So like, would it be like smart if you were like a blocker person to just have some in your pocket?
Well, it does expire. So they try and limit the stores just so that they don't have to restock it too often. But I don't have no idea how much it is.
Not too, isn't it?
It's just
Same
fat
as TPN and
Yeah,
like 2P.
yeah,
It's like
Just give them a stick of butter.
Stick of butter.
Stick of butter.
Inject a stick of butter in.
It'd be a just in case report.
Alright.
Propofol, TPN, hydrolabid, and clovidicine. I think are the only important things that we use.
Or the MCA oil.
MCT.
MCT.
What is MCT?
Bypasses
Triglyceride. It's like people
Okay.
drink like
All
coffee
right,
and
last
stuff.
question, I think, and then we should be done.
It's
Did
just
you
more
chart
like
that 5 milligrams of ephedrine for that girl? I just put the note in. I did not put the 5 milligrams back in there.
I usually just put it in the post cabinet. I haven't gotten an email about it.
You just did.
Well, questions, comments, thoughts? Helpful?
yes.
Yeah.
Very
Yeah, that's
Very
great.
helpful. Thank you.
Thank you.
Well, that's all I got. Enjoy your Friday.
Thank
you.
Thank you.
Weekend.
Yeah, I don't know. I didn't know if you wanted me to do that.
Thank you.
Nice to meet you.
Pack you.
Oh, I'm sorry.
Just put it in the pack. You know how
Is it wards or ICU?
Thank you for the JUL.
Oh,
The
hey,
entire,
I
there's
found it. He's behind something, so I can